Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today my topic of discussion is about a disease which causes central vision loss, that is macular hole. We will discuss its different causes, investigations and possible treatments. This is the fundus photograph of one of my patients who presented to my clinic with decreased vision in one eye. She was not aware of decreased vision, and it was a pure coincidental finding that once she closed her right eye, then she realized some black spot in front of the left eye, and that made her conscious of this problem. Otherwise, she was not having any complaint. So when she presented, we did routine examination. Her vision was counting fingers and in the left eye. And on examination, we can see here a well-defined central foveal crater over there, that is a macular hole, a full thickness macular hole. And this macular hole has also got a cuff under it of subretinal fluid, which is surrounding circumferentially this crater. This is the left eye of the patient. So it was a spot diagnosis of a full thickness macular hole. Macular holes usually are idiopathic, but they can happen in because of trauma, inflammation, or myopes who have long eyeballs. In those it can happen. And if we talk why it happens, the reason is that in front of retina there is vitreous, and vitreous sometimes exert anteroposterior as well as tangential traction. So these vitreous macular, the jelly vitreous macular, this traction is one of the cause of the macular hole. And when patient sees with the affected eye, he sees a black spot, which we in our term in language we call a central scotoma. So this is the photograph, and here it is shown over there. Now the vision is decreased, central vision, and if we put during examination, slit lamp examination, when he's sitting over there, light beam in his eye, that light beam, vertical light beam, will be broken from the center, and this test is called Varsky-Allen test. Now let's see about what we can do further investigations. In OCT imaging, we can see that there is a break, a crater, which is shown over there in this photograph, and it is a full thickness macular hole. We will talk in detail about their further classifications, and if we see as the two sides, in fact this is a cross section, as it is lifted there is some subretinal fluid also, and in the crater there is some residual tissues also. So this is the OCT of the full thickness macular hole. The fundus photograph of his other eye, the patient, disc, macula, central retina, no abnormality. A few drusen's were found over there. Otherwise retina was flat and no abnormality over there. Vision was 20/30, perfect vision, no abnormality. So basically she was using his right eye, and she did not realize that problem has been going on since when, no idea, and it was an incidental finding until and unless she closed the right eye, then she realized the problem in her left eye. OCT imaging of the normal eye, right eye, all the layers of the retina intact, no macular hole, foveal depression, no fluid, nothing break, everything is okay. So in contrast to the other eye, the right eye is normal. Let's talk about the classification of macular holes. The most widely used classification is the gas classification. And on this classification, different stages are there. Stage 0, 1, A, B, 2, 3, and 4. So basically 2, 3, and 4 are the full thickness macular holes. If it is less than 400, it is stage 2. If it is more than 400 micrometers but still vitreomacular traction is there, we call it stage 3. But if there is complete posterior vitreous detachment, then we call it stage 4. So the photographs we have seen here in OCT, we have seen there is no more vitreomacular traction, so it is stage 4 full thickness macular hole. Now we will talk about the different treatments of these patients. When we talk about the treatment of full thickness macular hole, it is pars plana vitrectomy, and that may be done with ochriplasmine. And after this, there is fluid air exchange. Mixture of gases can be used over there. For example, perfluoropropane, sulfur hexafluoride, air, combination of gases, very important. And patient stays in a face down position for a few days. The importance of internal limiting membrane peeling has been shown by this fact that this internal limiting membrane has got myofibroblasts, and it has got the processes of Muller cells. So it's very important to remove internal peel off internal limiting membrane. The second thing is the presence of the gas over there. It actually prevents the communication of vitreous fluid with the macular hole area. So it keeps it dry, and so when it remains dry because of this gas, it enhances its healing. Apart from this, some also use autologous blood to enrich that area of the macular hole, and also autologous platelet concentrates. These are also used, and to enhance the healing process over there. But when we talk about this treatment, the most important thing is the timing of the surgery. If we delay timing beyond 6 months, then actually what happens that the photoreceptors undergo atrophy, irreversible damage, and then even if we do the surgical closure, anatomical closure, the functional rehabilitation or functional gain is not that much. So timing is very important. It should be anticipated before 6 months. Apart from timing, there are some factors, indices, which can be calculated on OCT, which can help us in making a prognosis. These indices are hole forming factor, macular hole index, diameter hole index, and tractional hole index. These are calculated basically on OCT, their diameter, and then they can help us in making a diagnosis about the prognosis of the surgery. Also, the integrity of ellipsoid zone is also very important. As I mentioned earlier, that if the retinal photoreceptors undergo atrophy, then the results is not very good. So all these things are very important when we are going to do the surgery. Timing and the OCT changes, these help us in making a diagnosis and planning surgery. I hope my today's presentation will be beneficial to my respected audience in their clinical practice. I want to thank you for your attendance and attention. Thank you.